So first thing I want to start with before I share my screen, and hopefully you can see them well, but I'm always entertained by comics. And so in the urinary system, this one is an Argyle sweater. It says, "Bet I can pick which one belongs to asparagus without looking at the VeggieTales annual checkup." So I just thought that was hysterical, because when we ended last time, I was talking about urine and how, its normal smell is kind of that warm, kind of slight smell to it. But if you eat asparagus, immediately. So I thought it was hysterical that there was a comic about it. And then we're about to enter the ureter and down to the bladder. So I had to share this one too. It's one of the bats has one of those collar of shame that they use for dogs when they've had surgery or whatever, and it's because he's a bedwetter. So the peristalsis that's going to carry the urine all the way from your kidneys down through your ureters to your bladder, there you go. If I hung you by your toes, you would still urinate. And if you're upside down, you'd want one of those collars too. And then last, we're not there yet, but I just wanted to show you what the kidney stones look like. Here is a really nasty one. I guess I could turn it right side up so you can see the verbiage with it, but oh my goodness. These are very well-rounded. The ones that I have in a little clear case that I pass around, they are sharp. They look like a sand spur, and they were very painfully donated by a previous student, actually, who gave them to me. I thought that was pretty awesome. So
how big is that stone?
How big is this one? The one in this picture is...
Yeah, I can't read any of the literature on it.
Well, one tiny box is 1 millimeter. So it is 1, 2, 3, 4, 5 millimeters. So half a centimeter square, basically. And it's kind of strange.
Ugh.
Yeah, I know, right?
If they surgically removed that one, or did the patient actually pass it?
No, they had to surgically remove that one. Yeah. I think it was sitting in some calyces. Remember the minor calyx and the major calyx? I think it was sitting in the calyces. So cool, right? See, I can still figure out how to show you Sue's. Ooh, my God. Not as many as I'd like to, because I got some x-rays in here, but I don't think they'd show up well, so whatever. All right. Moving on now that everybody should be here. I don't have anybody in my waiting room. Okay, so now I'll share my screen. One moment, please. All right. Screen sharing. Here we go. All right, everybody see this? The structures for transport and storage of urine. So do you remember in A&P 1 with the tissues and transitional epithelial tissue? Remember what it was for? Anybody? No? Nobody?
Respiratory system?
Bladder.
Nope, nope. No one, no. Storage. It's about stretch. Okay, so transitional epithelial tissue is about stretch. And you'll find it in the mucosa of the ureters and of the bladder because it allows for stretch. And thank goodness.
Did you not hear me when I said bladder?
I did not. Gotta say louder.
I was like, what, really?
Yeah, stretch. Bladder stretch, yes. Okay. All right. So anyway, so when you look at the ureters, they've got an adventitia of this loose connective tissue, just keeping them in place. They have an outer longitudinal and outer circular and inner longitudinal layer of the smooth muscle, whose job is to help with peristalsis. And then it's the transitional epithelium that allows it to stretch. There's also a folding to it, so it stays in kind of a collapsed state, which is a good idea. You don't want like a really open tube because you don't want stuff backing up easily from the bladder. Okay, so the big thing is that as anything moves down here, it'll kind of stretch the epithelium and then it'll trigger peristalsis. So it'll milk it along. So that's why really you could hang by your toes and end up filling your bladder, and then yeah, it could get messy. Okay, so when you look at the bladder, urinary bladder, and then the exit with the urethra, with male versus female, the bladder is held in place, okay? It's retroperitoneal. It's sitting on the floor of the pelvis. It's a great place because there's lots of room down there unless you add a baby, really, okay? That's about it that's going to occupy space in competition with it. So there are ligaments. And so the ligaments are the urachus, the lateral umbilical ligaments, and their job is really to hold this bladder in place. I don't know if you've ever heard, but there are advertisements about that for a while there, and it's been some years, but there were all these billboards about, have you had a bladder mesh sling thing? And, you know, we lawyers can help you sue for this, you know.
I remember those.
Yeah, okay, then see. So it's because over time, especially in women who have had babies, who have kind of stretched things around down there, sometimes the bladder kind of drops, and that's a problem. So because if it drops, you get more urinary retention, and the more you hold on to urine, the more likely you are to grow bacteria, and then things go bad from there. Okay. So anyway, so the urinary bladder is held in place by these ligaments. It's got rugae in there. What are rugae for?
Absorption.
Nope.
Surface area.
Nope.
Stretch.
Churning.
Yeah, stretch. I heard stretch, not churning. No, we're not churning. Stretch. Nothing to churn here. There's zero absorption in here. Zero. Okay. Once you make urine, once that drip comes off of that renal papilla and into that minor calyx, there's no takebacks anymore. You have done all you can. The last tweaking, remember, was done in the distal convoluted tubule and the collecting duct, because that's where the aldosterone and ADH were working. So that's it. We're done. Once it drips into there, urine will come and it will not be reabsorbed at all. So therefore, all the bladder is a stretchable holding tank. So the transitional epithelium helps, and so do these rugae. So it can really hold quite a lot. I remember one time when I had to straight cath a guy who had some prostate enlargement problems, and I've never seen anything like it. It was completely milky that came out, and it came gushing out. The poor man was about to have his bladder rupture because I had to clamp it off. It came so fast that I actually had to clamp it when it hit 1.2 liters, because you really can't let too much out of time or the blood pressure will plummet. So it was like, whoa, and there was still plenty left in there. He was that blocked up. It was really awful. So it'll really stretch. Features in here, this triangular region that's defined by the two ureteral openings. Notice the ureters come down to the bottom and open up at the bottom of the bladder, and then the opening to this urethra. They form a triangle. They call it the trigon. Okay. So it's basically the funnel to the urethra. That's what the trigon does. All righty. There is an internal urethral sphincter on both males and females. And then there is an external sphincter. The external sphincter is the one that you can control. Okay. So this is the one, that external sphincter. There are these exercises that are called Kegel exercises. And so if you're a woman and you have given birth, then you would for sure, at least you should know about Kegel exercises. And it's where you start and stop your flow of urine just to practice so that you can get your urinary continence. You want to make sure you're not leaking when you don't want to. So here's the thing. this is every time I talk about Kegeling, I just have to laugh because an educator colleague of mine who has retired, and she lives out in Seattle now, but Judy and I were talking one time, and she had a whole song about Kegeling that was to, as we kegel along. But it was very, very funny. And then she said, you know, I could be Kegeling right now and you wouldn't even know it. And I said, you're right, I wouldn't, right? Because you just clench and unclench, clench and unclench. And so I looked at her, I said, are you Kegeling? And she just grinned. So all I can think is, you know, we all could just sort of sit and Kegel.
Can men do Kegels?
Absolutely. Men should be Kegeling too. Women and men. But especially women, and especially as we age, women are more likely, especially if you've had kids, to suffer the stress incontinence, like, you know, you sneeze and oops, you cough.
We're just chatting about that.
Oh my.
I can't jump on the trampoline anymore.
Oh
And
dear. They'd have to hose the trampoline off, huh?
well, it's not that bad, but
Okay. Well, anyway, so Kegeling is the thing to do. So I kind of forget about doing it until I talk about this stuff and I think, oh, and so for the next few days, you know, I'll think, oh, I should Kegel a little bit. You know, I'm getting old. I got to make sure that, you know, I'm not one of those who goes, tee hee, oops. Right. Okay.
I got one weird question. Does that help the muscles? So if you want it to be like after it stretches out everything. So does it help
Everything.
Everything down there?
Tighten the JJ? Is that
Yes. I don't know. I wanted to ask, does that actually work for that too?
Not that I'm aware of. It's really pretty specific to the external urethral sphincter, but it does tighten up your, you also are tightening your urogenital diaphragm that, you know, just the whole thing comes up. So it's not going to hurt. It might help a bit with.
I've heard that helps after kids and everything, but yeah.
It could. I don't know. Tatiana just joined us and missed the whole Kegel thing. Guys, you'll just have to try it yourselves. It's that start-stop urine flow. It's all a good idea to do because really, as we get older, and if you're lucky, you get older. If you're not lucky, then I guess you don't have to worry about it because you'll die young, but let's not go there, right? Okay, so anyway, so back to the bladder. So now that we've been Kegeling, the bladder, the walls of them, you've got the transitional epithelial tissue lining it for stretch. You've got the rugae for stretch, but the muscular wall, that muscle actually has its very own special name. It is called the detrusor muscle. You'll need to know that. It is still the same circular muscle stuff. It's that muscularis, but it is called the detrusor muscle. Okay, so know that term. All righty. So now we've got this bladder. And let's just talk about how it is so perfect for its job. It is the perfect shape. As a matter of fact, in the olden days, and maybe still some places, they would take sheep bladders and they would blow them up like they were a balloon and let them dry, and they became bodas. They became their water canteens in the old days. Then, so we've got a great shape. It's a great one for collecting fluid. We've got the stretchability because of the rugae and the transitional epithelium. And location. I mean, just location, location, location. This is in a fabulous place. Down in the bottom of your pelvis, retroperitoneally, there's no competition for room unless you get pregnant. And that's the irony of pregnancy, because here you go. You've got this kid who's growing in there, and especially when you're full up with your last trimester, now you've got, not only do you have a bunch of something else pressing down on your bladder, so you have less capacity of your bladder, but you also have greater output because you're making urine for more than one person. It's not just you. You're also doing, assuming single occupancy, another being in there. If you've got twins, then all right then. So no wonder you don't want to go on a road trip with a woman who is pregnant. You don't want to be the woman, right? Got to stop every 5 miles like, oh God, I got to pee again. Okay, so from the bladder, our holding tank in its perfect location and its perfect design, let's get out of here. So the external urethral sphincter is the skeletal muscle one that we get to choose. The internal one, of course, we don't get to choose. It'll relax when the bladder gets to a full enough stage where it says, oh, I got to go. So the actual urethra, it starts out with a transitional epithelium up by the bladder, but as we move our way along, it goes to a pseudostratified columnar. It's not ciliated because we're not sweeping things along until we get to close to the outside, and that's when it's stratified squamous. And that's why we can put in catheters, because we aren't going to rip anybody up, because it is a stratified squamous, non-keratinized, but nonetheless, Foley's can be inserted, straight casts can be inserted. We can stick a tube in here and not tear you up, okay? So male versus female. So as you can see, the female is really short. It's only about 1.5 inches long. That's it. It adheres to the anterior wall of the vagina. In the guy, you've got something that in total, and most of it's inside, but you've got a total expanse of about 8 inches, okay, about 20 centimeters. And they have different names for the different parts. So the part that passes through the prostate is the prostatic urethra. The part that's down here that's going through the penis, through the spongy tissue, is called the spongy or penile urethra. And in between, there's this no man's land. It doesn't belong to either the prostate or the penis, so they call it the membranous urethra. Okay, so right in here, we're not in the penis yet, but we're not in the prostate anymore. It's sort of like the way we change names with the femoral artery becomes the popliteal, becomes the anterior or posterior tibial, because we change locations, we got to change the name. All right, so there's a pathway. Did you notice that? Prostatic urethra to membranous urethra to penile urethra or spongy urethra out the external urethral meatus. Yeah, okay. All right, so now we get to pee or not to pee. By the way, pyelogram is a pretty cool thing. It's where we inject you with, and I'm getting to it later, but since the picture's right here and we're just kind of page turners in the book, this picture is over on page 1004. Yours is in color. This one's more black and white. But anyway, what they'll do is they'll inject somebody with a radio opaque dye, okay? And then they can watch as it flows through. And when you have renal problems, there are 3 places where things can go wrong. It can be either pre-renal, in other words, the blood supply coming to the kidneys. It can be intrarenal, so it's some problem, a blockage, a flow problem, something's wrong inside the kidneys, or it can be post-renal, which means in the urethra, the ureters, the bladder, somewhere along in that part. Okay, so when they inject you with this dye, remember, we're shoving through really fast through the kidney, so you can see this opacity, radio opacity. In other words, it shows up as white. Denser it is, the whiter it is. Bones come as white because they're dense. So anyway, you can see here, you've got, here are the calyces, and we're going to the renal pelvis, down the ureters, and we get to the bladder. So this is a very normal looking pyelogram. Okay, cool beans. So if we had like a really narrow part here, and I do actually have a picture of that, but it just isn't going to translate in this milieu, but where it's really dark right in here, and that means that there was a narrowing where they couldn't get through. So what they did is they put a stent into it to open it up. Okay, make sense? Okay, all right. So now this is the 2P. The fancy name for urination is micturition. So please know that word. Micturition is the urination reflex. We had the defecation reflex. Now we've got the micturition reflex. I don't know why we didn't just call it the urination reflex, but we don't. So stick with micturition. So here's what happens. Okay. And this is on page 1005, 1005. Okay. So you get a load of urine into the bladder. takes about 200 mils to get in there. So when you get about 200 mils in there, the walls have stretch receptors and they say, we got stuff in here. I think we should get rid of it. So the stretch receptors go two directions. It's a parallel processing thing. So we have the stretch receptors that tell the brain, I need to pee. And then we've got the others that are just a spinal reflex. So the ability to urinate, the Micturition reflex, is a spinal reflex, but we do know when we need to because you know, right? It's like, oh man, I wish before I'd sat down here, I had taken care of things. All right. So this spinal reflex, what makes sense is, remember, the parasympathetic nervous system is in charge of SLUD, salivation, lacrimation, urination, digestion, defecation. So parasympathetic activity goes up, sympathetic is going to drop. And what that does, this reflex, spinal reflex, causes the detrusor muscle to contract and the internal urethral sphincter to open. So now you up in your brain say, now's not good, right? So then you go and you clamp down on your external urethral sphincter and you don't urinate because we say, yeah, I don't want to do it. So we went through this way where we say, now's not good, not going to do it. So what'll happen then is the reflex, the stimulus dies down, and then along comes another 200 mils. So when the next load comes in here, it's going to be the defecation reflex. When you've got the load of stool that comes into the rectum says, yeah, I think we need to go. And then you say, yeah, not now. And it'll keep backing up until you've got constipation and then fecal impaction. Here, though, it'll keep telling you and it'll die down until it can't die down anymore. You know what I'm saying, right? I mean, everybody, you get to that point where you're going, I got to go now or it's going to get messy, right? It comes to a point where you cannot ignore it. It's not like the impulses will die down at all. It's on your mind fully. And what will happen then is that your higher brain, your I'm thinking about this stuff, is going to say, well, you know what? It's time. So I'm going to now open that external urethral sphincter. Now, do you always want to? Not necessarily, right? There are times when you go, I can't do it now, but you can't control it because it's too full. Does that make sense? You will void. You will micturate at some point if you get too full. It's just the way it is. Okay, does that make sense? Everybody good?
Yes.
Okay, so the Micturition reflex is a spinal reflex and you can override it, but only so far. It is not like defecation where we can just sit and keep getting drier and drier and drier. There is no absorption in that urinary bladder at all. Okay, so everybody all right with the urinary system? So time for the screw ups. So we've looked at the pyelogram. And I did show you the kidney stones at the very beginning. Hopefully everybody was on by the time I was showing that. Then there are some terms. There's anuria, polyuria, oliguria, and dysuria. Okay, ready? Let's start with polyuria because you already know.
It's a stopless urination.
Yes, it's too much. It's just lots, right? We expect that when we have like diabetes mellitus or insipidus. Okay, so we've got polyuria. The opposite of that is anuria, which means without urination. In other words, if you're putting out less than 50 mils in a day, that's called anuria. That's a renal failure, and that's where both of them are failing. That's a bad thing. This is where people go on dialysis when they have anuria, okay? Unless they can figure out what it is with the IV pyelogram and fix it. Dysuria is painful urination. That's where, you know, the most likely cause is you've got urethritis. You've got you're heading towards a bladder infection. You have a UTI, a urinary tract infection. Urethritis gives you that burning, that's dysuria, okay? If I climb higher, then the bladder gets infected. That is cystitis. If it climbs higher than that, it becomes pyelonephritis. Pyelo means pus. Nice. Pussy kidneys. You don't want pussy kidneys, okay? Because if they get pussy, and it's usually E. coli, that stuff that's coming out the backside, right? So E. coli contamination for girls. Big message from your public health people. Wipe from front to back always. When you're wiping a patient or a baby, wipe from front to back. Little girls, it's a big deal because if you put E. coli in there, then you head them right up to the urinary tract infection. That's a bad idea. The other one,
bacteria I see from UTIs all the time.
yeah,
Mm-hmm.
yep, that's the popular flavor. We're going to talk about girls versus boys shortly again, I think. But let me finish with oliguria. It's not on your list, but it's a term that makes sense for you to hear. Oliguria means not much urine, okay? And you could have oliguria how? What might cause you to have oliguria that you could fix yourself?
Dehydration.
Dang it.
Exactly. Dehydration. Okay, so then drink more and you'll fix your oliguria. It could be a problem though that it's, maybe it might be a renal problem, but hopefully not. Okay, so now I just want to talk about with the urinary tract infections, UTIs, girls versus boys. Over back to this. It's a plumbing thing, people. So when you look at the male urinary system, this is all stratified squamous on the shaft of the penis, the glans penis. In order to infect a male, it's got to get into the external urethral orifice. It's a dry world out there. Now we'll get to girls. When you look at the way a girl is set up, okay? If you look at the perineal region, in the front, you've got a clitoris. Then you've got the urethra. Then you've got the vagina. Then you've got the anus. And it's all in one nice moist triangle, or actually not triangle, a diamond shape. And this is a grand total of 1.5 inches. Can you see how it is that women are much more prone to getting UTI?
Monica needs to be let back in.
Do what?
Monica needs to be let back in.
Oh, okay, gotcha. All right. Okay.
Sorry.
No, thank you for saying something. It wasn't showing up as a big pop-up. That's usually it'll pop up, but not so much this time. So thank you for telling me. All righty. Let's see. So anyway, so girls are much more likely than guys. All right. Antibiotics will cure UTIs, but you have to get on them. All right. And you have to take them all the way in. You know the rules with antibiotics, right, peeps? You don't take them just until you feel better. You take them all the way to the end. I had a very interesting conversation with a male student of mine many years ago, and he wanted to know if he should start taking his antibiotic again for his bladder infection because it had come back and he had some left over. So we talked about the reason that you need to finish it, because all you do if you stop early is you've killed off the weak ones and left the strong ones, and now you got a nastier infection. So I'm sure you all know that, but just in case you didn't, I'm saying. Okay, incontinence. If you're a baby, you do not have control over your external urethral sphincter. It is not incontinence, okay? It's developmental. They just do reflex voiding. You can't control that when you're an infant. If, on the other hand, I, at my age, did not control what came out of my bladder through my urethra, I would have urinary incontinence, okay? Because at this point, I'm an adult and I should be able to control it. But over time, so, we all need to Kegel, right? Especially ladies, let's all Kegel. All right. And the last thing is urinary retention. And urinary retention is, it can happen to anyone, certainly females who have their ligaments stretched out and things drop, and then you've got a problem. But guys, the most common cause of urinary retention in men is this prostate gland, because the prostate will continue to grow through the life, and it eventually closes off this prostatic urethra. It's called benign prostatic hypertrophy, and it just blocks this down. So if you see an old guy and you happen to notice the front of his fly, his pants, and he's got various and sundry stages of urine spots drying, he probably has a prostate problem. He probably has prostatic hypertrophy, and he's probably getting close to needing to have somebody go in and do what we call a transurethral prostatectomy. So they go in through the urethra and they basically rotor-root this out to open it up for them. It's called a TURP, transurethral prostatectomy, TURP. Okay. I'm pretty sure it's not much fun. Okay. We good with the urinary screw-ups?
I had a question. How about like when you hold your pee so long and like your stomach just swells and swells, and then when you finally go to the bathroom, you can't go anymore? Like nothing comes out? Like you
I
really
have
have
not heard of that. I am
Never?
Huh. That
You
sounds
know, like
good.
when you're driving, let's say like it's a car ride and you're driving and you're like, oh, the next exit, and you really got to go and you get to the bathroom, it takes you a while.
Oh, because you've been clamping down so hard, it's probably just hard to let go. That's all. If you've been holding really tight for a really long time, yeah, it's probably just a matter of the muscles kind of gone into a, have you ever like held on to something? Have you ever held on to something really tight and then tried to let your fingers go? It's the same idea. You've just sort of, the muscles have clamped down and you have to purposefully relax them. I imagine that's what it is. I haven't been there myself, and you're my first person who said that that's happened. That sounds like really no fun.
You can ask like teachers and all about it.
Yeah. Okay then. But I've never heard of like the stomach swelling up and stuff. But yeah, when your bladder is full, it will bulge forward. You can feel an overly full bladder for sure. Okay. Any other questions about bladder stuff? Are we good with that? Okay. All right. How'd everybody do with the fluid electrolyte thing? Was it an adventure?
I didn't do too bad. I got some of them wrong. It was I had a little bit of a hard time understanding it, but once I figured out what was normal, it was a little bit easier.
Okay, cool. All right. Did everybody do it? I hope so.
Yeah.
Okay. All right. That was another one of Sue's flip the classroom, make you think about it before we get to it thing. All right. So, yeah, I haven't gone in to see what the scores were yet. I thought I'd just sort of wait and be surprised. That and the fact that I'm at work, and so it's been a little crazy here. Okay, so fluid and electrolyte balance. So we're in the next chapter now. Let me find our pages. So this picture is over on, let's see, a version of it is on page 1013. All right, we are juicy. I don't know if you realize that, but we are juicy. So the amount of juicy we are varies with our age and our gender and how much we weigh. So who's juicier, a 4-year-old or a 94-year-old?
4-year-old.
Of course, yes. The younger we are, the higher our percentage of juicy. That's why they just look juicy when they're little. Gender, who has more water? Guys.
Females.
Guys, yes. Why?
Guys?
Guys.
I thought it was female.
No, guys are juicier. Ooh, I heard I didn't hear the fee in front of the male. No. So it's guys. Why would that be then? Now that you know the answer.
They have more muscle mass.
Yes, absolutely.
Oh, I thought it was because like girls carry more body fat, like their breasts and butt.
That doesn't have that much water in it.
And you just explained, Beth, why it is that women don't have as much proportionally.
Because muscle has more water and then adipose.
Think about salad dressing.
Yeah.
Right? Oil and water, they don't mix.
Yep.
Yep, you gave the exact reason as to why.
Males
are juicier. Which brings us to the other one that, proportionally, if you have the same body build people, but one has a whole lot more fat than the other, then the proportion of fat will decrease the proportion of water. Okay. All right. So these different fluid compartments. we've got intracellular versus extracellular. I want you to notice that more of our water, about 2/3 of our water actually, is intracellular. And then when we look at the extracellular stuff, this rest of the stuff, you've got interstitial and you've got plasma. These are our big compartments. Interstitial is a big category of stuff. So when you talk about interstitial fluid, this is all those things that we've talked about, like your lymph, CSF, cerebrospinal fluid, your synovial fluid, your GI secretions, the aqueous humor in your eyes, saliva, those kinds of things, all those secretions, serous fluids. Those are all the extracellular fluids in the interstitial compartment of extracellular. Plasma is obviously, we know where that is, right? That's going to be hanging out in your blood vessels, we hope, or in the heart. Okay? So when we look at the components of these things, this is really a fabulous table. And in your books, just turn the page and you'll get to it. It's over on page 1014. So with our different electrolytes, our different solutes, let's start with the ones that we really know well. Okay, you know, electrolytes, they have ionic bonds, right? We put salts in water and they break up into two particles. We should already have a familiarity with osmotic pull. Osmosis, water is pulled to numbers, not size. Doesn't care how big you are. All it cares about is how many you are. Okay, so with the electrolytes, when you put a salt into a water, like sodium chloride, you end up having two particles for one. It's going to pull more of the water. It has a greater osmotic pull, okay? If I put glucose into water, it's a non-electrolyte. They're covalently bonded. When you put glucose in, you get one glucose for one glucose. So therefore, this is going to count one for one. They don't have as much osmotic pull. Does that make sense? Because it's all about numbers. I kind of think of it as like seats in an airplane. It doesn't matter whether you have a great big butt or a little butt, you have to pay the same thing. It's one seat. So if I have two little butts, it's two seats. They count as two. So glucose, lipids, urea, these things are molecules that you put them in water, they stay as one. They're non-electrolytes, therefore they don't have as much water drawing power as the electrolytes. So that's a big deal, because remember that whole mantra of water follows sodium and other solutes. But I put sodium first just because sodium is an amazingly important determinant of where water goes in the extracellular compartment. Okay? And who hangs with sodium? Oh, that's the chloride. So thinking about that stuff. So if we look at these, red is for the plasma, green is for the interstitial fluids, and yellow, or whatever this is intracellular. So I look at sodium and I look at potassium. I have a lot of sodium outside the cells. I don't have much inside. I have a lot of potassium inside the cell and not much outside. Who made that happen? We got something going on that's making this happen. Do you remember? There's a little mechanism that keeps clicking along.
Sodium potassium pump.
Bingo. The sodium potassium ATPase pump. So you already knew this. You knew there was a lot of potassium intracellularly and not much sodium. You knew there was a lot of sodium outside the cells and not so much of the potassium. We had that from A&P1, and kind of I keep saying it again and again, right? Because it's that whole thing with depolarization and all that. Okay, so next, if you look at calcium, where would you expect calcium to be loose? Not bound up as hydroxyapatite, but just loose. It's going to be more in this extracellular fluid. If I look at the magnesium, it's more intracellular. Oh, look, bicarb. Where do we carry our bicarb? Well, it tends to be out in the fluids, right? This is our important alkaline reservoir. Okay, this bicarbonate, extracellular. We kick it out of the cells. And then chloride. Chloride, wherever sodium goes, these guys are married. Which is why, too, if you eat really salty food, think about what happens to you. Okay. You got a whole bag of potato chips and you eat the whole bag. And then you're really thirsty, right? Because you had really salty stuff. So now you drink a bunch. So what happens to you?
You
Where is it
swell
going?
up.
You swell up. Exactly. You know, a gal I went to nursing school with, she definitely was you can't eat just one potato chip. And so she never bought potato chips because on those occasions she'd eat the whole bag. And then her knuckles would go from sticking out to being dimples like on a baby because she just puffed up so much because water follows sodium and other solutes. All right. So does this make sense so far? We good? Guesses? Okay. All right, over here, let's look at the proteins. Does it make sense to you that I would find the most protein intracellularly, the least just out in the interstitial fluid, and then the next amount in the blood plasma? What's this red doing? What's this bar about? You remember? What plasma would we be thinking, or what plasma protein would we be thinking about? What's our number?
Right.
Albumin.
Albumin.
Yes, bingo, albumin. Okay, so that, and then there are plenty of other proteins in there, of course, right? Because we've got the procoagulants, we've got all sorts of things, enzymes. There are a lot of different ones, the antibodies, gamma globulins, all that stuff. So we expect a lot of protein in the plasma, but we would expect most inside the cell because the cells are the busy factories. They're busy doing stuff. We would expect protein to be really concentrated inside the cells. Okay, so does this table make sense? Kind of based on what you had? This whole chapter really is reviewing, it's putting together the pieces that we've kind of already looked at.
It's kind of review. That's what I noticed, like the pH
know.
balance. It reminds me a lot of chapter 2 and
Exactly, which is why this should be a fairly comfortable chapter. And it's kind of why I felt like I could trust you to manage the assignment before we even talked about it. All right, so let's move things among compartments. And this is where I would like to be drawing on a board, but that's just not going to work. So what we're going to do is use this picture, which in your books is over on page 1015. Okay. So what we're looking at is the movement of water. Okay. So if we think about movement of water moves very freely across all of these different membranes to the different compartments. It gets to go into the intravascular compartment, the interstitial, into the cells. Water just freely moves along. That is osmosis, right? It doesn't need a ticket. It doesn't take active transport. It just moves along. And where it goes is depending upon the osmolarity of the extracellular fluid. Okay, that's going to determine where the stuff in the intracellular fluid compartment goes. So let's think this through. In my cells, let's pretend that in here I've got just gobs and gobs of my proteins and all my good stuff because I am dehydrated. So what happens when you're dehydrated, right? There's not enough water. So water now is getting pulled out of the cells because what's happened is first the blood plasma starts getting more concentrated. Can you see how that would happen? If I haven't gotten enough water in, this blood fluid is going to start getting more and more concentrated. Now, as it gets concentrated, what happens is now the interstitial space, the water in here says, I'm going to move out here. I'm going to be drawn to the more concentrated compartment of the blood plasma. You with me so far? So as I'm drawn from here now, whatever's in here now gets more concentrated. Can you see that would happen logically? So now this is more concentrated. So the water inside the cells now starts moving out into the interstitial spaces. So you get this osmotic pull That's a series, because as I'm dehydrated, this gets concentrated in the blood, which then pulls it from the interstitial spaces, making them concentrated, which then pulls from the cells. All right, you're ready to have some inappropriate amounts of alcohol? So if I have, let's say it's a night where it's like, oh my God, what a day. I think I'm just going to pull out a bottle of vodka. So now I've got the bottle of vodka and I'm feeling so bad about the world that I pour a great big drink of vodka. So when I get all that ethanol in me, what happens to my ADH output? Remember?
It decreases.
It drops. Okay, so it goes down. So as it goes down now, am I going to hold on to my water?
No.
No. This is why that whole expression of you only rent beer, or you drink a beer, you pee a 6-pack. Okay, you've inhibited your ADH. So now you're drying up. So as we dry up, right, this is where now the blood plasma gets more concentrated, which pulls from the interstitial spaces, which pulls from the cells. So now the cells start getting dehydrated. They're getting shriveled yuppie, and they don't like it. So they're doing it all over the place, but they're also doing it in the brain. So when your brain gets dehydrated, your brain goes, yeah, I'm so not happy. And that's your hangover. So remember what I told you when we were talking about ADH, and that what you should do is drink as much water as you can before you go to bed if you were stupid with alcohol. So you drink as much water as you can, take some aspirin, B vitamins, neuroprotective. And then what are you going to do? Soon as you've been asleep for maybe an hour or two, your bladder fills.
The bathroom, drink water.
Got to get up, pee, and then you drink more water and go back to bed. And then a couple hours later, so you're trying to replenish so that your intracellular compartment doesn't get dehydrated. That's when you're going to feel really.
Why aspirin over ibuprofen?
Because the NSAIDs can have some problems with your liver.
And aspirin's not as hard on your liver?
Right. The aspirin is not. Aspirin,
I know that Tylenol's horrible for your liver.
Tylenol's the worst. But yeah, you don't want to drink with ibuprofen either. Tylenol's the worst. Acetaminophen, absolutely. But yeah, no, you stick with aspirin. Aspirin is going to make your stomach bleed a little. It will always. But that's okay. Stick with aspirin.
Okay.
And besides, it's cheap and it's made from willow bark. I mean, how more natural could you get? Of course, cyanide is also a natural product. So is arsenic, lead. Yeah. So natural doesn't necessarily mean good, right? When they say all natural what? Should be your next question. Okay. So anyway, so water moves freely among the compartments. So when we're moving, do you remember back with the capillaries, and we had those two opposing forces? You had the hydrostatic pressure, you know, that physical push against the walls of the capillary, and then the push back from the outside, right? You've also got the osmolarity, the osmotic pressure, and oncotic being a subset, talking about the proteins. So the osmotic pressure is really the osmotic pull, right? So we got the pull in, and we've got the pull out, and we've got the push in, and we got the push out. So the hydrostatic pressure, if you have water with solutes, the hydrostatic pressure from the capillaries is going to push water out of the capillaries and into the interstitial spaces, right? That's when you get the edema. If you don't have enough osmotic and oncotic, the proteins, not enough proteins, that's when you start having the water say, well, why would I be inside here? I've got the pressure, I've got no solute pulling me in, so I'm going to push out, and I get into this interstitial space. Okay, makes sense? All right. So the other name for oncotic pressure that you will hear in the world of medicine especially is colloid osmotic pressure. Do you remember colloids? Those are like the jello inside your cell. It's colloid. So another name for the proteins, the oncotic pressure, which really should be oncotic pull, but they didn't ask me, is the colloid osmotic pressure. It's the proteins part of osmosis. Okay, everybody got that? Okay. All right. So osmosis, everybody moves across, happily, the water goes back and forth. Active transport for the bigger stuff that says, hey, you know what? Amino acids, those things, I need to move into my cells or whatever by paying some kind of channel and active transport, maybe. Who knows? I might have to pay for it, but at least I need to have a channel. I might have facilitated diffusion like glucose, where it's like, well, you know, I can get into the cell. Gases like oxygen, carbon dioxide, they just diffuse across. And so, you know, it just sort of depends on what you're getting. But the big thing we're kind of focusing on here is honestly the electrolytes and the water. Okay. Everybody okay? All right. So let's talk about water balance. So input versus output. The vast majority of the water that you get in, how do you figure you get it?
You drink it.
Yeah,
No.
absolutely.
Yeah.
You drink it. That's exactly what you do. Okay. So when you're drinking, you're triggered by your thirst reflex, right? Or some people just like to drink. My husband calls himself a psychogenic polydipsic because he just likes drinking things. So he's always got a bottle of water next to him or something, a glass of something, because he just likes to drink. So some people just like putting fluids in their mouth, but mostly it's triggered by a thirst instinct. But that
Excuse
reflex.
me, I heard that fruit eaters, they do not need to drink like a lot of water.
Well,
They
that's right.
replenish the water balance with fruits.
Right. Because why? Are they eating dried fruits? I'll bet you not. Right? They're eating real fresh fruit, right?
Fleshy, yeah.
Yeah, because about 30% of a normal diet anyway, your food, unless when you eat it, it poofs into powder, in which case we'd probably all start aspirating our food. But most food has moisture in it, fruits being a great one. I know if you're really thirsty, eating some grapes or an apple will really slake your thirst because they are filled with a lot of water. Also sugar. So they do a little bit for the hunger, they do a lot for the thirst. And a lot of times hunger is really you're thirsty, you're just misinterpreting it. But yeah, absolutely. Fruit is a way of getting water in. So probably about 60% of the water that of the water that you get in, that you ingest is just by drinking it. Then you've got about 30% is because you don't eat poof dried stuff. But then that last 10%, you made it. I mean, did you, now that we've been through metabolism, did you know before metabolism, when you met it, and it might be you had it in biology, so it's not your first time, but you realize most people don't know that they're busy manufacturing water. I think that's kind of amazing, right? Be amazed with me. We make water because protons are the terminal electron. They're the acceptors are oxygen, right? To make water. All right. So let's talk about what makes us thirsty. When we are thirsty, there are two factors to it. One is a drop in your plasma volume. Because if we have too low of plasma volume, then what happens to our pressure? Drops. Low blood volume, your blood pressure drops, right? So a drop in your volume of your plasma, so your hematocrit has risen by about 10% is going to make you feel thirsty. It triggers this, okay? If the other way of getting there is not to lose water, but instead to add solute. So if you increase your plasma osmolarity by about 1%, again, you'll be thirsty. It's that bag of potato chips phenomenon, right? You eat some really salty food, you are thirsty because you have now added salt to your compartments. And so therefore your body says, I need water. Okay.
What is Pedialyte and like the electrolytes? Is that better than water?
It depends on what you really need. We're actually going to get to that. So hold on to that thought.
Okay, just
a great question. We're going to actually address it. How about that?
Okay. Thank you.
Bad. Okay. So anyway, so what happens when either you've lost about 10% of your volume of your plasma or you've added about 1% of your osmolarity is that your mouth dries up, right? Because you're not going to produce saliva because you're holding on to your water, right? So you get a dry mouth. When you have a dry mouth, you feel thirsty. It's a subjective thing. So when you subjectively feel thirsty, then what happens is you put something in your mouth to wet it up, right? So what happens first is when you just get your mouth wet and those osmoreceptors in your mouth detect that, oh, hey, we've got some stuff here, you already start slaking your thirst. It decreases because your body is pretty sure that if your mouth is wet, it's going down the pipes, right? Heading down to the stomach. So you're going to be okay. Until, of course, the stretch receptors down in the stomach say, hey, you were just chewing gum. You lied to me. Or you just put an ice cube in the mouth and nothing happened. You lied to me. And then when your stomach and your small intestine say nothing came, you're going to get thirsty again. But it's the principle behind what we do when we have patients who are NPO, in other words, nilo per oro, which means nothing by mouth. So their mouths get dry. And so as their mouths get dry, what we can do is maybe let them have an ice chip, or we put a swab in their mouth, a lemon glycerin swab that gets it moistened, and they feel better. Now, are they going to stay feeling better? Of course not, because we lied. We just made their mouth moist. But that's that first part. And it's a good idea physiologically because under normal circumstances, nobody's just going to get their mouth wet and then not swallow. So nature is assuming we're going to be doing the logical right thing, but sometimes we lie. And so then it'll kick back in to be thirsty, but it stops it so that you don't over drink. We're trying to prevent that just guzzle, 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 which is not okay. And we'll talk about that in a minute, but you don't want to end up with too much water and dilute yourself out too much. That makes sense? Okay. It's quiet, so I'm figuring so far so good. Okay, so now we've put water in, water out. Obviously, the most obvious way, that was repetitively redundant. The most obvious output of water is our urine. Okay, and we put out about 1.5 liters a day, and we've already met that in the previous chapter. This is called our sensible water loss. Sensible doesn't mean, well, it's just the smart thing to do. What it means is that it's the stuff we can measure. Can you measure diarrhea? Sure. If somebody vomits, can you measure it? Absolutely. Are those normal? No. Okay. We certainly are losing liquid in insensible ways. In other words, you are sweating. Every time you exhale, it's moist. It's why you can use it to steam up your glasses so that you can rub them clean with a cloth. You could cry. I guess you could cry buckets, but generally people don't measure tears. You know, the patient who's sitting there, wait a minute. Before you do any more crying, I've got to get a little container under here so I can measure all your fluid output, So it's an insensible loss. Another thing is, besides the obvious of sweat and exhalations, but feces. I have never yet met, and I've been a nurse for over 20 years, never met anybody who poofed out fecal powder. It's because there's water in feces. Even when you compact it, it's still moisture stuff. Okay, cool. So those are all considered insensible. Anything that we can measure like vomit or diarrhea, that's not within the realm of normalcy. That means that you're sick. So we don't count that as our normal stuff. Okay.
And can sweat also be sensible water loss?
No, because again, it's almost like tears. And some people, there are some folks who have excessive sweating as a disorder. Okay. But we never do measure that, and because in order to do it, you can't just pour it into a pitcher. I mean, I guess what you could do is take the saturated cloth and weigh it, because we do that with diapers. When you've got a brand new person who comes out in the world, the way that we measure output of a baby, a neonate, is to actually weigh the diaper, because we know how much the diaper weighs dry and we know how much it weighs when it's full of urine or whatever, and we can calculate the actual moisture. But Yeah, you would never put sweat into the sensible water loss. The only thing we characterize as sensible is the urine output. Okay, we good? Okay. All right. So dehydration, let's talk about the screw ups. So dehydration, all it means is it's a negative fluid balance over time. In other words, we're not getting enough fluid in for how much fluid out. So how could we end up in dehydration? You tell me.
You don't drink enough.
Okay, you don't drink enough. You maybe were out working in the sun, you sweated a lot, maybe you had diarrhea, maybe you were sick and you had diarrhea and you were vomiting, you didn't even know which end to put on the toilet, whatever, and you're not compensating with enough water. Okay.
Can you get it from sunburn too?
You can. Let me ask you how you think you could.
Because your vessels are dilating because of to get more blood, right? And then you're losing.
Depends on the degree of burn. Okay. If you peel. Now, if it's a little first degree where, you got that sunburn red, but you keep your skin, doesn't peel away, you're just doing some sweating and you're back to you didn't drink enough for what you sweated out. But if you get a burn that peels away skin, remember, is a very important physical barrier for waterproofing. Not only water coming in, but water going out. So a burn is one way, absolutely, of becoming dehydrated and shifting fluids, actually, because that weepy serous fluid that comes out, when you get a burn or the blister pops, right?
Yeah.
That stuff that's so bad for keeping you safe from invaders too. But you can lose water. A big burn is a really bad thing for dehydration. And
yeah, I guess it wasn't just sunburn, burns in general, like
burns in general.
Yeah.
If you get to second or third degree,
Yeah.
First degree, the skin stays intact. Okay. Second degree is the blisters and the skin peels off. Okay. So another way is hemorrhage. If I lose a lot of blood, I've lost not just red blood cells, but I've lost the plasma. So I've lost blood volume. Hemorrhaging would definitely be a way to become dehydrated. And then we also know some very specific pathologies. Tell me what they are. What is going to cause you to have dehydration?
diarrhea.
Fever?
Give me a name of a disease.
Diabetes.
Yes, diabetes mellitus, diabetes insipidus, right? Those would be two really good ones. All right. All righty. So if I have a chronic dehydration problem, or if I have one that's just acute, either way, am I going to make much urine? Of course not. I got to hold on to my volume, right? So that's when you're going to get into the oliguria. So if you're dehydrated, this is when you're going to get the really dark yellow urine and not much of it, right? So if you look in the toilet after you have urinated, then it's really dark yellow and you haven't taken any B vitamins to be the reason for it. Drink more. You need more water, okay? Your mucous membranes are also going to tell you your mouth is dry, right? Okay? All right. Okay, so now on to Beth's question. There's the thirst mechanism, and I totally forgot to turn the page. I get on my discussions, and there it is. Okay, so here's that. Sorry about that. So if my osmolarity goes up or my plasma volume drops, this is where my osmoreceptors, and who was in charge? I know you know the hypothalamus, right? Okay, so we dry our mouths up, we feel thirsty, and that's when we start our drinking. Okay, plasma volume dropping, for instance, if you have hemorrhage, would be one way to get there. If you're dehydrated because you just have not been putting enough fluid, then again, we're going to kick in our renin, angiotensin, aldosterone, and we're going to hold on to fluids again. Okay, so this is a very good picture. So you've got this in the book as well as in the PowerPoints in your course. All right. So let's talk about, I'm going to skip through this one at the moment. Here we go. Water balance. Okay. So I'm going to tell you a story. I spent many breaks between semesters on horseback in various and sundry places on the United States continent. Okay, so horsebacking in the middle of nowhere, and one of them was in Monument Valley. And when we were out there, we took a gal with us. You had to be able to ride, and you really needed to know how to camp because we're out in the middle of nowhere on horseback with guides, and there are no amenities, right? You dig a hole and bury your excrements. So anyway, so we're out, and this one gal who is an executive assistant. So this is a girl who, for her days, wears hose and her hair is done right. But she knew how to ride, and she wanted to come with us, so she did. So we're in Monument Valley in May. It's hot and dry. It's Navajo land. And we're out there, and it's an 8-hour ride to get to our base camp in the middle of, it's the desert. So we get there, and I've noticed Linda has been drinking water. And we get there, and Linda has become gray. She was not gray before. What had happened was Linda was drinking water. What are you sweating out, peeps? Just water? When you sweat, what's in sweat? Just water?
No. Electrolytes.
Yeah. Electrolytes, wastes, but solutes, right? So it's a solute and water. And that's why, you leave sweat stains. They look like salt dried up. Yeah, well, it did. So Linda was drinking water, but not adding in the salts. When we got to the base camp, what had happened was she had hypotonic hydration, known as water intoxication. So here's what happened. So as she drank, I'm going to jump back to this one right here for a second, okay? She was drinking water. She was absorbing water through the gut wall into the plasma, diluted out the plasma. The osmolarity here dropped. It looked to the interstitial compartment. The water moved into the interstitial compartment, diluted it out. Looked to the cells, moved into the cells. The cells started to swell. So as the cells were swelling, they're swelling everywhere, including in the brain. And the brain is in a closed container. The bones don't let it expand. There's a foramen magnum that things can herniate down through, but that's a really bad thing. So anyway, so we're looking at Linda going, oh no. So I'm in the middle of Monument Valley. It's not like we have bags of IV fluids, but what did we need to give her in order to draw the water back out of here, out of the cell? What did she need? Salt. She needed solute, correct? Because she needed to get solute to get into the blood, which would then get into the interstitial space, right? Because water then would pull out of the cells into the interstitial spaces, dilute that out, move to the blood. So we gave her this wonderful stuff. It's called Emergency, and we had these powder packets. And so we had her drink a nice concentrated slurry of this stuff, and she survived. She even went on other horsepacking trips to Canada and stuff. We tried to kill her there too. So I'm a very dangerous friend to have. I try to kill people because I do things that other people shouldn't probably necessarily do with me. But anyway, so she had water intoxication. And what happens is she becomes hypoosmolar, right? Low osmolarity. And so one of the factors of that is hyponatremia, because remember, the electrolyte who's most in charge of controlling where water goes is sodium. Okay, extracellular compartment, it's about sodium. So when I added sodium back into her body because she drank it, then she rebalanced by pulling it out of the cells. Does that make sense? Okay, so if we were in a hospital setting and we had IVs and wanted to do it quicker, or they weren't responsive and couldn't drink something, luckily we caught Linda before she went unconscious, and then things would have been really bad. And I think a lawsuit might have happened, because I don't remember that we had her sign anything saying, if we kill you along the way, please don't have your family sue us.
So my question
got
is,
echo.
we have receptors that tell us when we're thirsty. Don't we have receptors that tell us when we've had too much to drink?
Nope, because in general, nobody does that. Biology doesn't expect us to do that. I know, right?
She was just guzzling water just to guzzle it, and
Yes, because she was figuring she was being really smart. She wasn't drinking because she was thirsty as much as drinking because she figured she should. And you
how
do
does
that-
that present?
Huh?
How does that present? Like,
What did she look like?
yeah.
Shock. She was going into shock. Cold, clammy skin, gray, change in mentation. Not good looking.
How much water would that take? Like, how much would you have to drink to have that happen?
Well, it's the amount versus the amount she sweated out. So it was about the imbalance, not so much the volume itself as the how much she sweat out versus how much she replaced with just water. So there's no real, I can't think of any kind of absolute. Plus, it depends on the person.
Because she was drinking so much, did that cause her to try and sweat more?
Nope.
No, it doesn't.
Nope. Nope. Yeah. So there you go. So that's what happened to her. She became edematous. She was getting nauseous. She had muscle cramps. All this stuff was happening because what happened was she became basically overhydrated and hyponatremic. Hypo low, natrium is sodium, right? Na. Hyponatremic. Got it?
So if she would have added just a little bit of salt to her water every once in a while, she would have been okay?
If she had Pedialyte or Gatorade.
Yeah.
Yeah, that would have been the difference. Taking salt tablets. Most people, when they're out in the wilderness, they take salt tablets. We just happen to, instead of that, because I'm not a big fan of salt tablets, I'm there. But the Emergency is tasty. It's orange or lemon flavored, they've got citrus flavors. And so it's got what you need. It basically is powdered Gatorade.
Yeah.
Okay. So anyway, drinking too much water too fast. You could also get there if your kidneys were failing. That's another way to get this way. But sort of the more logical way is because a lot of people think, some is good, more is better, most is bestest. You get these people are drinking they got their huge gallon jugs and they're drinking all this stuff. If they're not careful to also get solute, then they can put themselves into this water intoxication state, hypotonic hydration, hyponatremia. Bad news stuff. Okay, good. All right. So another thing that can happen if you get too much water in you is the edema, right? And there are different ways that you can end up in edema. Let's see. By the way, I don't think I said where this was, but it was on page 1019. All right, so let's see. Edema this is when you get extra fluid in the interstitial space. And this is that puffy person. So for instance, if you have hypertension and you just have too high of hydrostatic pressure in the capillaries, it'll push the water out, right? If you have too little plasma proteins, you've got more solute here than you have in here. Your oncotic pressure, your colloid osmotic pressure in your plasma is too low. Hypoproteinemia, whether it's because you didn't eat enough protein or whether because you have liver failure and you're not making your albumin, that will put you into an edema state. Does that make sense? Everybody okay with edema? Kind of sound familiar from cardiovascular system and blood plasma? Another way you can end up with edema we talked about when we went into the lymphatic system. Remember, if you remove the lymph nodes in the axillary region, then you're prone to lymphedema distal to the disruption in the pathway for flow, right? So people who have had mastectomies. You can't play around with that arm on that side because you've got really poor, compromised lymph drainage. Okay, you get lymphedema.
What about allergy?
Allergy is, it's again back to the vascular permeability increasing because you've got histamine release, and so therefore it leaves the capillaries. Good example. Absolutely excellent. Okay. All right.
Do you have such quinque swallowing of quinque? When it's this is a condition when a person is swallowing, his head, nose become extremely big. Quinque.
I don't know that one.
Sorry, I'm just like comparing the
Yeah.
same.
Yeah,
So
interesting.
so the person needs immediately administration of adrenaline or EpiPen.
Yeah, if you've got an anaphylactic reaction, you mean?
Yeah, anaphylactic shock.
Yeah.
But quinque, it's like maybe name of the scientist who diagnosed this precondition, like when a person became swollen. Sorry, I'm just like asking. Okay.
No, I haven't heard of quinquin.
Quinque.
Yeah, I don't know that one.
Sorry.
That's okay. Cool. I'm glad I don't have it, and nobody I know has it.
My son had like twice this diagnosis when he has an asthma. When he tried some products that turned him to be reactive with his allergy reactive. So we experienced this issue.
Quinquin, I don't know that one.
Okay, sorry.
No, don't be sorry. It's always cool. This is why I do this. I never know what somebody else is going to ask, and sometimes I don't know. I haven't heard that one. Let's see. Oh, I wanted to get back to, where am I? I've got two screens going on, and so sometimes I get the cursor hung up in the wrong place. It confuses me. Okay. So I wanted to go back to this slide. So we've talked about the hypotonic hydration. So what we'd want to give is salt. So in the world of medicine, if we had had an IV, we could have just given her some hypertonic solution, right? A more salty than normal saline, higher than normal saline. Over here, if I am dehydrated, so therefore I've lost water, so it pulls from the blood, which then pulls from the interstitial spaces, which then pulls from the cells, right? Because water keeps going to where there's a higher solute concentration. So I dry up out here, I start drying up here, which pulls from here. Okay, so when I'm dehydrated, if I have too high an osmolarity, what would I give them in terms of IV fluids? I've got, remember my choices. There's hypertonic, isotonic, hypotonic. Hypotonic. Okay. So here's a good example. For this one, I could have a little old lady. Okay. Here's a picture. She comes into the emergency room. Right now, of course, you don't come into the emergency room unless you're really sick, because we're looking at COVID-19 now. So it changes who wants to show up here. But anyway, I'm going to finish with this, I promise. I lose track of time because it's dark in my office. So let me finish this and then I'll turn you loose. Okay, but anyway, so what she does, she comes in, she says, you know what, I figured out that I have this little problem of if I sneeze or if I laugh or whatever, I pee, and I don't like that. So if I don't drink, then I won't pee myself, right? So they figure this out. Oh, and by the way, on top of that, bless her heart, this poor girl woman has a problem with some upset stomach. So she uses her grandmother's recipe, which was baking soda. So she's got sodium bicarb in her, okay? And we'll talk about the pH next time we play, but she's got sodium bicarb, so she is hypernatremic. And she is dehydrated because she hasn't been drinking. So she has a double problem, and she's lost her mind. So she comes in, everybody thinks, oh, well, she's in her 80s. She's just old. She's a raisin. She's just confused. No, What you need to do is give her hypotonic hydration, like half normal saline, plump her back up, get the sodium under control. And turns out that this woman is brilliant and has been taking care of herself for many years. And she's an author, who knows? Okay, so when you screw around with fluid electrolytes, it's a big deal. Okay, it can put you in big problems. Is everybody good with this stuff? Kind of reviewy?